I'm now joined by Professor Mayr and Professor Liener. We will talk about the best treatment approach for geriatric patients. Thanks for being with us today.
Thanks for having us.
Thank you for the invitation.
What do you think traumatologists need to keep in mind when dealing with a geriatric trauma patient?
I think the most important is to keep in mind that these are completely different patients than the regular adults. We have comorbidities, we have problems with osteoporosis, we have problems with the mind of the patient, with dementia, with delirium and everything else. And therefore, I think a co-management with a geriatrician, which is in best position to deal with these problems, is one thing that the most traumatologists should keep in mind.
What do you think are the best ways to adjust your treatment pathways for dealing with the elderly?
I think you have to address the surgical challenge by your surgical technique, which is early arthroplasty, rigid fixation and stabilization with intramedullary nails. And you also have to address the medical challenges, and that is with protocol-driven care and geriatric co-management. And the goals of the protocol should be early assessment of the geriatric patient by a geriatrician and early surgical care within the first 24 hours, immediate postoperative weight bearing and mobilization, geriatric co-management for polypharmacy and the comorbidities, and early discharge planning. And I think numerous studies have shown that this results in a reduction of mortality and complications and an improvement of functional results.
I think it is important to give yourself some credos in geriatric trauma care. Some credos like single shot surgery, which means the decision has to be made in the very first moment when the patient shows up. The best way to treat him with one operation. Mobility is over functionality. That means we have to keep them going, the patients. And it's a highly individual decision making in geriatric trauma care.
What do you think traumatologists often get wrong when treating geriatric trauma patients, and how can this be avoided?
I think the first misconception is that they think it's a singular orthopedic injury. And also the trauma surgeon might be the best person to treat the patient surgically, but not the best physician to address the medical problems. And that's why I think geriatric co-management is essential for these patients.
In my opinion also, there's always to reach full weight-bearing mobility. Yeah. That is one of the most important things from the traumatologist standpoint. Because we today know that conservative treatment might end up with a higher rate of mortality than operative treatment. And this is something pretty new. We always thought up till now that operative treatment is of risk for the patients, but the conservative treatment is in many, many cases more risky, especially with the mortality.
How do you think the treatment of geriatric trauma patients will develop over the next few years?
Hopefully, I think we can widespread it much more, especially the co-management with a geriatrician. Geriatricians are our natural friends. And trauma surgeons are natural friends of geriatricians. And I think this should be widespread all over the trauma units, which are dealing with geriatric trauma patients.
I think we will have mandatory geriatric co-management in the hospitals that are treating geriatric trauma patients. And I think we will have an increase of the number of geriatric trauma centers and a decrease in the total number of hospitals treating these complex patients.
Gentlemen, thank you very much for your time. Have a great Congress.
Thank you.
Thank you.